Joshi and Dr. Kandashora for taking the time out and teaching us and talking to us about vascular malformations today. So I'll pass the baton over to you, Greg. Thanks again.
All right, thanks everybody for joining us. As Toba already said, we're going to start off with Dr. Smith, and then Dr. Chen will be giving us a short discussions on cavernous malformations and AVMs. So to start us off with, probably needs no introduction, one of the leading voices in vascular surgery, Dr. Smith, who after a unfortunate injury, his career in rhythmic gymnastics was ended, and he went to Dartmouth for his bachelor's degree, Columbia for MD, Mass General, and then stayed on at Boston Children's and never left. He's the vice chair of neurosurgery, the director of cerebrovascular, and interestingly enough, has a graduate degree from MIT, which I think is pretty cool that he got just last year. So Dr. Smith will be telling us a little about cavernomas.
Oh, thank you very much. Now, I only have 4 hours here, so I'll try to rope through it very quickly. Let me see if I can get the slide up, the talk up for you here. So let's go share screen. Let's try this. Let's go share. And let me go to play from start. Is this working for you now without a bunch of weird stuff down at the bottom? Perfect. Well, thank you very much for the invitation. I'm going to try to just cover a little bit about some of the important things that we need to know for the boards, and then some of the common questions we might get asked in our practice. I don't have any disclosures to make other than it is really nice to be here in the group. In terms of cavernous malformations, one of the big things I get asked a lot is, what are they? Why are they a problem? And then, when you do have a treatment for these, what's the natural history? And then how do you decide how to treat them surgically? So I think many of us have seen these before, right? This idea of a mulberry. I've actually seen cavernous malformations, but I had never seen a mulberry before. There are sort of 3 mutations that are associated with these. I'll talk about them more in a second, but CCM1, 2, and 3. These are different genes that are found on chromosome 7 and chromosome 10. Essentially, they have these sort of bubbly type appearance that you can see here, which are really like dilated balloons, and they often have fluid layering in there where the serum will be on top, this white stuff, and then the blood products will level to the bottom. In terms of, their prevalence, they're slow flow vascular malformations, so they are not these sort of high risk bleedy things. They affect about 0.5% of the population. So they're relatively common. And the problem is they sort of lack the sticky endothelium, so they'll swell, then they leak, and that causes hemorrhage and direct mass effect. One of the things we've learned recently, and this is one of the board questions that may come up, is that particularly with CCM3 mutations, it affects the stickiness of the gut lining as well. And this allows these bacteria to get their lipopolysaccharide to circulate around in the blood. What's important is that if that gets up into the brain, there's this receptor, toll-like receptor 4, TLR4, and that's on endothelial cells. So if this, bug juice from the belly circulates around and it attaches to the receptor in the brain, that will further increase the risk of bleeding. And so this is a very interesting example of the microbiome and how this can affect us in neurosurgery. Most of these are single lesions, meaning they're one and done because of a somatic mutation that happened in one cell and made a bad copy of itself. But a number of them will be germline mutations, and you'll see them run in families. And these are usually mutations in those genes I mentioned earlier, CCM1, 2, or 3. And those make up about 90% of all the cases that run in families. So that's what they are and how common they are. The 3 genes, and these, are good to know for the boards. CCM1, 2, and 3, they make these proteins, CRIT1, malcavern, and PDCD10, which is not a bar in New York. But essentially, the CCM1 and 2 make this big protein complex, and they're involved in making endothelial cells stick to one another. And then CCM3 is essentially a separate thing that's involved in cell motility and adhesion. And because CCM3 interacts with more pathways, they tend to have a worse clinical phenotype. So that's just, if you remember one thing, remember the higher numbers where CCM3 is bad. Why are they a problem? Well, I think all of us in this audience know this. They can go from these little tiny nothings to, bleedy things. That's the fancy Harvard term. And they can compress surrounding tissue. They can irritate the neural structures by swelling in blood products. And in the brain, they can cause things like seizures or mass effect. So that leads to the question, what the heck do we do about them, right? We're surgeons. And this is where we really need evidence-based data. And I would suggest that if you have the chance and you're pediatric neurosurgeons that do anything vascular, two of the key papers to file away from today's lecture are the American Heart Association guidelines. They were published in 2019. The senior author was a total jerk. I don't like that guy at all, that Smith guy, but they really do tend to show a lot of the evidence-based medicine for moyamoyas, AVMs, and in this case, CAB-MALs. And then there are the national guidelines by the Angioma Alliance. Those are in active revision right now and should be out by the end of the year, but they were previously done in 2017. So if you want to see someone smarter who has written this with other, really smart people in the group, these are two papers to put away to take a look at. So the first question is, who do you treat? And if you're going to treat somebody, you need to know what the natural history is and then understand if what we're doing is better than a natural history. It's like playing at Vegas. What are the odds? So the bottom line is that many of these will present, at least in kids, either with seizures or with hemorrhage that leads to local neurologic deficit. And that covers about 2/3 of them all coming. They're found incidentally in about a quarter of cases or so. So little Timmy gets a scan because they fell off the bus, or someone, has a family history. But by and large, seizures and hemorrhage are the two most common. And almost all of them are supratentorial simply because that's where the greatest concentration of neural tissue is. Most people have a lot of brain unless you're an orthopedic surgeon. And so therefore it's mostly found up there. I can't tell the crowd with laughing with the Zoom things. I've always hated that. So the next question is, how often do you see new ones? If you've got a kid and you follow them, what's the likelihood of having new ones pop up? So if you have a family history, it's about 3% per year of getting a new one. Whereas if you've had radiation and it's radiation induced, it's about 2% per year. And if you have a single somatic lesion, it's very rare. It's about 0.4% per year. So they don't crop up a whole lot if you're not familial or radiation induced, but those other ones can, and it tends to be younger is more common. The other big question we get a lot is that what makes them bleed? And so this is a very common question you get from your family. It's like, well, can little Timmy go on a roller coaster? Can you jump on a trampoline? Can you play sports? And the answer is that probably you can do pretty much anything, and that should not increase or decrease the rate of bleeding, according to a nice paper by Heather Fullerton, a neurologist at UCSF. Infection probably does not increase the rate of bleeding very much, but blood thinning agents, while they're unknown, we usually say we would not put them on that unless we really needed to. So by and large, you can let them go ahead and play sports, although I don't like them doing things like football or repetitive strike, things like boxing. The next question we get is, hey, doc, how often do they bleed? If I've had one that's bled, what's the likelihood it's going to bleed again in the next year? If it's an incidental finding, you just see one showing up on scan, it's pretty rare. It's about 0.5% per year. So it's a pretty low likelihood of bleeding. However, if they've had a bleed already, the numbers go way up. So it's about 11% for all comers per year. And there's this clustering phenomenon, first described by Seppi Hanjani at the UIC, but in other places where the first 3 years, you have about an 18% rebleeding rate. And then if you can get through that window without rebleeding, it's down to about 5%. So they do rebleed, but it really matters whether they present incidentally or whether they present with a hemorrhage, and this helps you understand the natural history and whether you should intervene. The deal is that if you do rebleed, it's mostly in the first 5 years, which is why we tend to check these kids with 5-year MRI annual studies, and then we taper off after that. What about specific locations? If they come in, what are the natural history for different spots? So the basal ganglia are rare, but when they come up, we get a lot of questions about these. The bottom line is a lot of these folks may present with chorioathetotic movements, abnormal motor disorders or mood disorders. And what we showed in our small series here and others is that basically, if it's big and it's symptomatic, you can almost always take these out safely in the basal ganglia, and they do well. If they're recurrently bleeding, that's another reason to take them out in the basal ganglia. But if they're small and not symptomatic, we would suggest probably leaving them alone. Other locations, the most common one is a supratentorial lobar calf mal, right? We see these all the time. And the big thing is many of these will present with seizures. And if you take them out, whether or not you do any ECOG, associated seizure surgery, if you just do a lesionectomy, in our series, about 96%, and for all comers, over 80% will be markedly improved or absent with their seizures after surgery. And this does not necessarily mean you have to go after the hemosiderin. This is for all comers, and you have really good Engel grades with very low complication rates of less than 4%. So there's a really strong impetus, and I will tell you a little sneak preview. The new guidelines that are coming out have shown not only does surgery work really well to control seizures, but we're finding that medical management of seizure-related cavernomas tend to do a whole lot better if you treat them early. So point is, if you got seizures, take them out, just do it. So how can we treat them better? And this is just down the road. Surgery advances, brainstem cavernomas can be removed safely. One of my big rules, though, is I really like to see them come out to the surface. So looking for them to have a peel tract. I don't like going after them if they're not there. This is something where you can go subtemporal. There's a lot of different ways to skin a cat, but this is just an example of where you see it on the surface, and then a lot of these folks can do pretty well. Where they do poorly is if you try to go through the PIA and it hasn't come to the surface, and I tend to be very conservative with those. Another big thing is using ultrasound. Many of these deep-seated lesions, one of the problems is you get brain shift or they're tiny. And so one thing we've looked at is looking at catheter-based ultrasound use. And we looked at this with other things, including tumors, but basically, what do? We look at this with an ultrasound, we pass a catheter to the lesion, and then you just follow it right down to there. And we published this a few years ago. It seems kind of simplistic, but boy, oh boy, does it make it easy. We just did one a couple of weeks ago. But this is a choroid plexus tumor, but just as an example, you can just plop the catheter right in there. It only takes a couple of minutes. You just follow it right down the tract, and it is a very fast and easy way to get there. You have about 3 minutes of time to do it. It accommodates for brain shift. You don't have to keep coming in and out of your microscope or looking for things. And I think it's more accurate than either stealth and faster. So this is just an example of how you can treat these. And then, it can be customized for a lot of things, but I would suggest this is an option. Other ways we can apply these, 3D printing is something that some folks may use. We do this at Children's where we get turnaround time in about 24 hours. For complicated cases, it can be helpful. For the sake of time, I won't go through the video here, but basically these 3D printing things now are 98% concordant. You have less than 2 millimeters variation between the real world and the model, and you can reduce OR time by 12% in complex cases. So it's another way to think about trying to do this in a sort of faster and easier, safer way. This is a picture of what they do with me at work. They kind of keep me in the box when I try to get different ideas. But it is important to recognize that this is a field that's advancing quickly. We've talked a little bit about the biology of these, but there's also some great new drugs coming down the tract. These CCM proteins I talked about, they involve the modulation of downstream molecules like this enzyme called ROCK. It has a role of inflammation. There are ROCK inhibitors that are coming and are in clinical trials. We'll be reaching out to you about some clinical trials coming down the road. Looking at different sorts of vitamins, such as vitamin D and the microbiome I mentioned earlier. So I think there's going to be some very exciting advances that might put us out of business, but might be based in the biology of the study of these. And I think it's a really exciting time to be in neurosurgery, particularly in vascular. So in wrapping up, I hope in my timeline I had here for 15 minutes, cav mals are really a big healthcare burden. They're 1 out of 200 people, so they're around a lot. Not all of them need surgery, and in fact, most of them don't. But I do think understanding their bleeding risks, which ones are the bad guys, what you can help with and what you can't, is going to be where we have a role as surgeons, and then pushing the field forward with 3D printing, with augmented reality, ultrasound, and drug therapies are, I think, the future of this. So I thank you very much for your attention. I think I finished in my 15-minute window here, and I'll wrap up at this point.
All right, folks, just to let you know, we'll at the end, when Dr. Chen talks, then probably do a short answer session and then present 2 cases as well. So yeah, hold on to those questions. I know I have a couple just because I'm curious and people ask me about stuff, and I'm not a vascular surgeon. So our next speaker is near and dear to my heart, always the smartest person in the room whenever I'm in the room. Dr. Chen is a neurosurgeon at CHOP along with me. She got her bachelor's degree in Florida and her MD degree down there as well. Then decided to come north to Penn and did her residency and fellowship here. She's our trauma and vascular director at Children's Hospital of Philadelphia, and she's going to give us a background of AVMs.
Thanks. Can you guys see my screen? Great. Okay, the subtitle thing keeps popping up. It did that yesterday too. All right, better? All right, thanks for the introduction. So I feel like everyone, including Jeff, because on his PowerPoint, he has the same slide. So we must be getting the same slide somewhere. But you guys all know we don't have to, go through this. But obviously, AVMs are high flow vascular, unlike cavernomas. And the problem is that the artery is directly connecting to a vein, so the blood can't slow down. It's usually idiopathic, but obviously we see it a lot in HHT and other diseases, and it can occur in any part of the body, but obviously we're near and dear to the central nervous system. This is a lot of mutations. The only ones that I think that you really need to know for life and board exams, unless you do research in this, are the MAPK-RAS pathway, and also in HHT, there is several very common listed genetic mutations, and that is autosomal dominant. So I have that in highlighted here. And like I said, a lot of times they're with overgrowth syndromes, and people see a lot of AVMs with that. So outside of this CNS, that's very common. And so there are some genetics related to that. Symptoms and workup, I don't need to tell this group about it, but obviously it's dependent on the location. And, often they present with hemorrhage. So, very common story, they get a headache or they seize, they lose consciousness. And, it's different from the cavernomas, we all know, where they kind of, they come in terrible looking. So, often, depending on where you go, your head CT is a first line. And then, sometimes people follow it up with MRI, MRA, depending on, how practice. I always get an MRI, MRA, and then angiography plus or minus embolization, depending on what we're going to do with it. So I wanted to talk about there's always, every time there's some kind of conference, some vascular person gets up and everybody's like, the ones that next to the ventricle, they always bleed, or the small ones every bleed. And it's just like, you can't change your mind about it. They're just like set in their ways, So I think where that comes from is, in some old papers by Spetzer and stuff, said that some small AVMs, because of potentially higher pressure in the arteries, leads to more frequent bleeds. But a lot of people have done research in the more recent years and kind of don't think that is necessarily a factor in it. So the ones that the literature really shows is the deep location, maybe some problems with the draining veins or venous ectasias, and definitely deep location is a very big factor in multiple papers. And then some show that the large size bleeds more, some shows that the small size bleeds more. So that's why there's not like a true consensus about that. So, despite what one person is like adamant about it, it's really still a little controversial. So this is also a very important take-home message. So the percent bleeding risk, a lot of textbooks have it in the 1 minus the chance of no hemorrhage to the exponential of expected years of remaining life, which I don't really know how to do exponentials anymore because I still have to check my kids' homework with my calculator. So what I do is just 105 minus the age. So you have like a 15-year-old boy, 105 minus 15 and divided by 100, you're going to have like over 90% rupture rate, right? So that's like just the poor, no Asian. I'm like, all Asians everywhere just kind of curled up in their graves right now. Kind of poor man's math about their bleeding risk. So, it's true. So, I like to think that we usually quote about it. I tell patients about 2 to 4% because I like to kind of get that whole spectrum. But in a really good meta-analysis, about a decade ago, they quote about 2.2%. So that's still on that spectrum. So the higher the risk, obviously, if it's previously ruptured, and then in the first year is kind of really high and then kind of goes down back to normal-ish, the longer you wait out. So on the right side, we just more papers about what increases your risk of bleeding. So obviously we definitely know for sure, nobody's going to argue with ruptured AVM has a higher overall rate of re-rupture. The deep location, exclusively deep venous, drainage, associated aneurysm, prior hemorrhage, these are all things that people commonly think will be an increase for rupture risk. But what people also, it's like, old wives' tale, whether gender has anything to do with it, whether the small size, older age, those, a lot of people, studies have still not shown really any difference in them. So we all know, actually, I'm sure everybody knows both sides of it, but we're all very, very well-versed in the Spencer-Martin grading. And then, in the last decade plus, Alon and Young came up with supplementary grading, which adds in age, bleeding, and compactness score. So compactness score is basically how compact, it is what it sounds like, a nidus is. So obviously the more compact, the more likely that it's all going to be, nicely all resectable and everything. So these add points to your supplementary grading, in which in a bleed, it actually makes it easier, right? Because it's already separated planes. So that's why, yes is that. So that increases risk. Basically, what you have to think about now is anything over a 6 is probably not surgical. That's kind of like the bottom line. Treatment, I found this on the designer. I don't know if you guys they just do so cool designs on the PowerPoint these days. Anyways, so it's like, I don't know what they're trying to do because it looks like a brain, but it kind of looks like a tree, but I thought it was fitting. So treatment, sometimes in the HHT kids, right, they all get MRIs and they have a little, low flow, something, obviously you're not going to take it out. So in certain cases, maybe a serial MRI, MRA. These days, usually, if possible, we like to embolize them before surgery. And then, some people, we don't do it at our institution or where I trained, but some people do embolization followed by radiation and not necessarily surgery. So combination of all these, potentials, sometimes you do surgery and then there is a little residual, you think you may not be able to find it, and then it may be a good, radiation candidate. So it's not all one treatment. We're going to just go through a couple of slides about the treatment in the literature. I can't talk about AVMs without talking about the Aruba trial, which let's just not get into it, right? But basically, a couple hundred people, the bottom line was the medical group did way better than the interventional group. So they were basically like, treat headaches with headache medication, treat seizure with seizure medication, and then don't operate on anybody. But everybody knows the design flaws and, problems with it. So nobody truly uses it as a guide, I think, these days about it, but it's the only real, control trial. So some other studies, Davidson in 2010, 640 patients, they basically concluded what most people already kind of know, is that Spencer-Martin grade 1 to 2, there's a very small surgical risk. So if surgical, you should do it. And then anything in 3 and above, we got to just kind of weigh the risk and benefits of it. And a little bit about radiosurgery. So obviously good for small, deep AVMs that you think that, just by getting to, you're going to cause a lot of brain damage. But in terms of like whether or not it works, it really is honestly, it's very institutional dependent. So some of these, like the last study, they show that they didn't really have the middle study, they didn't show they had amazing obliteration rates, but that's also potentially because they were radiating really big diffuse ones that you weren't going to get a great obliteration rate too, right? There's really no way to necessarily control for that. But the take home message of all of these studies is that the obliteration rate is not zero. By any means immediately. We all know it takes years. There is still a pretty big hemorrhage risk within the first year or two. So when parents are like, well, what do we do, that is a real problem. Like you can have bleeding while you're waiting for for surgery. Like your risk potentially is just null if you have a complete resection. So that's basically about radiation. Just wanted to touch a little bit upon it. We can touch a little bit more when we go through the case examples. So I just wanted to show two kind of very simple cases. So this is a 17-year-old who was referred by optho because she actually presented with proptosis, and optho got a CT of the orbits and realized there was like a little AVM, just like you could barely see it at the edge of it. So right off the bat, what I wanted to point out is the blood flow has not gone to most of the brain yet, but has essentially filled all of the AVM. So this is a very high flow lesion. You can see in all these. And then in terms of the venous drainage, obviously deep venous drainage, and you can see that this potentially is causing proptosis just by, kind of like not a steal, but just the pressure from the venous drainage causing the proptosis. So post-embolization, this is a coil in there. You can see that the blood flow to the rest of the brain has actually gone to the rest of the brain before it completely fills, the nidus. So the flow has definitely decreased, immediately after angio. So and give me a thumbs up if you can see it playing. Okay. So this is just what I wanted to point out here is that just what it looks like, kind of annoying nidal vessels. If you get into it, it's just that it's not torrential bleeding because you're not like, causing any venous rupture, but I'll stop this here for a second, but it's just a little annoying ooze and you're clearly like in some kind of nidal vessel. So on the surface here, you can see that you have either some kind of dead or embolized arterialized vein. It's probably unlikely to be a feeder if it's just hanging out there. But these are also kind of arterialized looking veins. It looks like arteries, but they're, on the surface. And then so in this, and this is right frontal area, it's not eloquent at all. So you kind of just want to make sure that you don't really get into the nidus, all that much, or you're just gonna be annoyed at yourself. So you're just kind of coming around, taking out this en bloc. So that is some kind of venous or arterial supply to it that we're taking that's already blocked. So we're just taking it. This is down medial where the retractor is. And then this is kind of what you want to be left with. So we're in the Sylvian here. And then in a second, you'll see the coil, which actually just annoyed me because it's hard to buzz a coil. So I had to put a temporary clip on. So we're dissecting that off the artery just to make sure that we're completely dead. It definitely still Dopplered. So we're not completely dead there. So we put a temporary clip on so that we could just continue working and make sure that we cut that as the last. This, you can't really tell anymore because it's essentially dead, but this is the draining vein. And so what you want to have at the end is just a meatball on a string so that you take the last draining vein at the very last point. So that is here, taking the last point of the coiled feeder, and then just removing it. So that's the intraop angiogram. These days, I can't remember a last case I haven't done an intraop angiogram in. I think that's kind of more standard of care these days. So this is what it looks like. Okay, so this is another example of kind of what I was talking about with the radiation. So very similar, except for the drainage is superficial, right? Right frontal lobe AVM, simple, kind of, lower grade. She went to get 4 opinions, and I said, if you can do surgery, and I think I can do surgery without having a problem, I would always recommend surgery because you have 2+ years of radiation. And I don't think she had one now, but later we find out she had kind of an intranetal aneurysm. So anyway, she comes back a month later and she's bled a lot. She still looks fine. There was like a little intranetal aneurysm that we embolized. So at this point, like, my question is like, do we really need to take this out? Because she's gotten her definitive proton therapy, right? But I just thought it would be overall better, for the family's like well-being and everything, state of mind, to just remove it. So that leads me to intranetal aneurysms, in which you can still bleed from the AVM. Just because you have an intranetal aneurysm doesn't mean you're always bleeding from the aneurysm, but it definitely, you need to, characterize your aneurysm into intranetal, which is within the AVM nidus. It fills early during angiography. Flow-related proximal is on the major artery with eventual supply to the AVM. Distal, which you really don't have to worry about it, because once you take out the AVM, that will probably die off, and then something unrelated. So these are all kind of things that we've all, been taught over the years. So, which leads me to my final case. And I know that we weren't supposed to do cases, but I feel like you can't learn this without like actually talking about it through a case. A 14-year-old who came in, sudden onset weakness, obviously aphasia. We're dealing with very, left dominant lobe here, and you can see a little bubble through on the CTA there, which if you look at the angiogram, this is kind of like a bilobed aneurysm along with the AVM. So this is a micro, selective angiography, but because of, you can see like the vessel loops back on itself, it wasn't able to be embolized. So we just did a standard pterional crani. This is basically where we made a little window into the temporal area, and we're basically just like kind of skeletonizing along the sylvian, opening up, and then getting into, a little bit of AVM bleeding, which is just, well, okay, that's a blood clot, but just little oozy, annoying nidal stuff. So now we can see, and I think you can tell, so that's just like the annoying bleeding nidal stuff, that there's a mass, right? There's a mass there. So we're just kind of coming around it, trying to just kind of separate it out, to just try to take out this AVM en bloc. I'm sorry, the aneurysm en bloc, and resect it, because that's most likely, where it bled from. So we're just, oh, that was my mistake, my bad. Fast forwarding it to this area. So that's kind of where the neck is of that, and sucking out some of the more of the clot to get just a better access to it. And then this is probably, yeah, this is like, okay, so we've disconnected everything and we're going to take it out now. All right. So then, there's still a little AVM on the sylvian MCA vessels. So I just skeletonized as best I could to remove the rest of it. So this looks pretty good on, the angiogram, and she's had subsequent angiograms, and it's looked great. So that brings me to my last point, is that follow-up. We know in kids that even if you think you took it all out and it looks great, they can still recur. So we did a study years ago, but we also, we stick to that. So I've changed it a little bit. I still get an angiogram at 1 year. and I still get it at 5 years. But instead of graduating them at 18, I feel like in the young 20s, some of them still recur. And so I will keep kind of following them until their younger 20s. But I don't just one and done these angiograms. Like I've seen it before come back like a lot. And then I just get yearly MRI, MRA. If there's anything that's really concerning on it, obviously I'll get the angiogram ahead of time. And that's it.
All right. We're going to present 2 cases too, but I thought maybe, I don't know exactly how the normal format is, but maybe if the folks out there want to ask a quick question of the 2 experts before we get to the cases, and we're going to discuss the cases in depth, that would be great. I can kick it off with some questions. So, Dr. Smith, how do you handle, do you handle the radiation or the genetic induced cavernomas differently? When do you decide to operate on those? I mean, you can see patients 5, 6 cavernomas in there. What is your decision-making process with those patients?
Yeah, so at the end of the day, the likelihood of operating on radiation-induced or familial cavernomas has a much higher threshold, meaning I'm less likely to operate on them unless I'm really pushed. The deal with radiation-induced cavernomas are, again, this will be coming out in the new guidelines, but many of them may not actually be true cavernomas. They may be just microthrombosis that occurred because the vessels got zapped. So they may not have the same history, may not need operation. I tend to operate if they're clearly growing, bleeding, causing symptoms, or the other option is the oncologist sometimes is like, holy crap, this kid's been radiated because they had a tumor. Is this a tumor recurrence and not a cavernoma? And sometimes you'll do that for oncologic purpose. But those are my criteria for radiation. For familial cav mals, I really hate operating on them unless they're very clearly demonstrating progressive increased growth over time, if there's seizures that localize specifically that location, or if, it's a one-time, like big mass effect major problem. Otherwise, I'm much more tolerant of small amounts of bleeding and growth. I tell the family sort of 10% changes are okay. And those are my criteria there, but I'm much more conservative is the short answer.
Great. There's a question from the chat. Go ahead.
Dr. Smith, here's Guilherme Piedade, the fellow from Miami. What is your opinion on the role of, on the protective role of aspirin in cavernoma bleeding?
Yeah, so I mentioned that sort of very briefly on the slide at the very end. It turns out that probably it is very minimal. I mean, the idea behind it is they say, well, these are slow flow, lumpy, turbulent vessels. And so they get constipated essentially if the blood is stagnant and it gets, bound up and then it can bleed. And it's the same idea sort of as in a very simplistic way, sinus thrombosis in my head. Not in my head, but in my head. But it appears that this does not appear to have a lot of help necessarily. So we have gotten away from using it. It is currently sort of a bone of contention amongst the group, so we'll see what the final results are like. But my guess is that it is not going to be something that's recommended. It's safe to use if you need it for another reason, if they have cardiac problems or moya or something. But my guess is that we are probably not going to be recommending it in the pediatric population as a routine use.
Thank you.
Can I ask a question? Can you guys talk about AVMs and when they present with hemorrhage, how do you deal with them, your timing, and sort of, do you do it right away? Do you wait 4 to 6 weeks? Pros and cons of that?
Oh, that's a great question. I didn't touch upon that because, so I honestly will do them within the hospitalization, and that's a peds specific thing, because I think that if I send them to rehab in 4 to 6 weeks, they're going to be amazing because they're kids most of the time, and I don't want to take the setback, especially like, for instance, that girl with the aphasia. Like if I let her go to rehab in 4 to 6 weeks, she might get all her speech back, then I'm gonna rehinder that. And also, especially with the blood clot, I feel like they heal better if I get rid of the blood clot, if it's like a big blood clot. So I won't necessarily rush into it. Like I won't do it, same day, like as they come in. I mean, if there's something high risk, we'll embolize it, but I will almost always, if they bleed, do it within that hospitalization, probably within that week.
Yeah, I do it very differently. I totally agree with what you're saying about how the kids look good and it's hard to stomach when they feel all better and you bring them back. But the reasons that I tend to, obviously, if they're sick, if there's mass effect, totally agree. You do it as you need it. If they can tolerate it, we may just take the clot out and wait. But the advantages to waiting, in my mind, and with some of the stuff we've published, would add that first of all, the brain is much more relaxed and easy to work with if it's not all irritable and friable. And at least in my hands, in the first week or two, it can still be pretty grouchy. The second reason is, and this is where I think it's very important, is that we found that about 15% of AVMs will have missed parts of the nidus. And we've now looked at our 15-year follow-up of AVMs, and there's a higher rate of recurrence or residual in acutely operated AVMs than those that are done in the 4 to 6 weeks time frame. And the last thing is our fellow from last year, Solomon, has worked, not Solomon, Shivani. Solomon's great, but he's not working on this. To show that the rebleed rate in that first 4 to 6 weeks is essentially negligible. So the trade-off is the benefit of waiting, is it an easier surgery? Is it less likely to have recurrence or residual? Is offset by, is there any risk of rebleeding or death in that sort of 1 month-ish period? And I think the numbers would suggest that it's not. It's totally valid to do it any different way, and those are great reasons to do it, directly. But this is the sort of rationale as to why I tend to wait if I have the luxury of not having mass effect or immediate problems.
I have one quick question. What about congenital AVMs? How do you handle those? It presents with a bleed in neonatally. Are those a different beast? Are they, does it portend good, bad? Will they burn themselves out?
So, I mean, I think they're exceedingly rare. We see them, once every couple years, I want to say. They typically are not, you would think like they would be associated with HHT or something like that, but they're not necessarily always. One of two things: either we definitely know for sure that AVMs are not always congenital, meaning that like you can have a completely clean MRI when you're 1 or 2 or whatever, and then develop it later on. So the ones that are like the infants that come in, they either tend to be in a location that is, you really can't operate like deep or holohemispheric, or present with a seizure or bleed, and it's really difficult because there's no real good treatment for it, because they can't get radiation. They're too young. Even protons, like they just yeah, and eventually they might keep bleeding, but they usually burn themselves out. We will embolize high risk features of it, but like if it's really coming from deep, there's really nothing you can really do that much.
Are they more often mixed? Will there be like a peel fistula along with an AVM, or?
I haven't seen. I mean,
We
I
definitely
don't
see
know
more
that.
peeled fistulas than we do
Yeah,
AVM.
those are different, and I think those are easier to treat endovascularly. But the true like holohemispheric deep AVMs that are in the infants, they're like a different entity. And yeah, I do think that they eventually kind of burn themselves out.
Yeah, so some of them, I agree completely. I would say that there is a slightly higher rate of RASA1 mutations in some of these kids, so it's worth checking them for a RASA1 mutation. They will tend to, at least in our very limited experience, sometimes have AV fistulas as well, and those, as she mentioned, can sometimes be treated endovascularly. Another important thing to think about is that many of these kids will have coagulation problems, which can lead to additional difficulties. So it's worth keeping an eye on their coagulation problems. Either some of them tend to be about 30% will have hypercoagulable states, particularly with a RASA1 mutation, and that may lead to outgoing brain constipation problems, and is worth taking a peek at. So we published on that I don't know, like 10 years or so ago, and again, it's an exceedingly rare problem, but those are just a couple of points to think about in terms of the management and workup of these. But the individual architecture is really what drives the decision-making tree, and they can be pretty hard, as you mentioned.
Well, while
I
the
refer them to CHOP.
That's right. Well, while the rascals think of more questions, we'll move on to the presentations by the two fellows. The first one is from Solomon Oshie. I hope I pronounced that right. He's the vascular fellow with Dr. Smith. So he's trained a undergrad at New Mexico, trained at Columbia, and a Mayo resident, and is now a fellow at Boston. And on his webpage, one of his interests was sleep. Which I don't know if that's interesting.
I've seen that during the cases. He does it so well.
And he's going to give us a case today. And then please, guys, I encourage you to log in, talk. You can do it under an assumed name. That's fine. Maybe not.
Can you guys see my screen okay? Yeah, okay, very good. Well, thank you for the introduction. Sleep was definitely crucial in junior residency. Hopefully not so much now. So I'm going to be presenting a bread and butter cavernoma case. This is the case of Dr. Smith, just kind of stimulate a little bit of discussion here. So this is a 5-year-old female. She presented with headaches, nausea, vomiting, past medical history. She has a known CCM1 mutation. She's had seizures in the past, and she's on an anti-epileptic agent. And she also has multiple known cerebral cavernous malformations, and those have been serially stable and monitored. So workup MRI was performed when the patient presented that demonstrated hemorrhage in the right parietal cavernous malformation. On her examination, she didn't have any focal neurological deficits, and otherwise she was appropriate for age. So this is the imaging that was obtained when the patient arrived. As you can see, they're all axial cuts. We have T2 on the far left, and then flare, and then SWE. So on T2, you see the classic mulberry appearance. That's in the mesial parietal lobe. And again, on flare, we don't see a whole lot of edema. And on the SWE imaging, you see the rim of hemocytic deposition around the cavernous malformation, which is very classic and typical of these type of lesions. When we look at the T1 imaging, you see again 1 by 5 by 2.4 centimeter cavernous malformation in the mesial parietal lobe, right adjacent to the occipital parietal sulcus, with a little bit of local mass effect and effacement of the sulci. And you see the T1 hyperintense consistent with more acute blood products. So one other thing to just keep in mind in terms of treatment planning, the red arrow here points to an adjacent cortical vein. It's probably one of those bridging veins that we all love, especially in an interhemispheric approach. Just one more thing to keep in mind when we're thinking how we're going to approach this from a treatment standpoint. So this vein basically crosses over and then is going to make the treatment a little more challenging. Before I proceed and talk about what we did and the specific steps and approaches that we did, I'm going to sort of defer to our faculty here and see if they would like to chime in with any questions or comments.
Nope, you're awake and doing great.
So this is a kid that's got CCM mutation, right?
Correct.
So
Yeah.
presumably, is this blossomed then, or?
Yes, this is definitely grown with new blood products in it.
By just serial imaging, though, not symptomatic.
No, she was symptomatic. The patient presented with nausea, vomiting, and headaches, but they were non-focal on examination.
And had seizures, I believe. Is that right, Solomon?
Yep. She had seizures in the past, and then she's been on anti-epileptics for quite some time.
Well,
So out of curiosity, did you do this with ECOG? Would you do this with ECOG? And what's your take on that? If you have a clear lesion with a seizure background with an associated lesion, would you ever consider doing grids? Because we've seen that done before too. So I just wanted to get your take on that. Would you ever consider doing that, or would you just do an ECOG, or would you even forego the ECOG altogether?
If it's relatively simple like this, I will just do the surgery with no ECOG or epilepsy stuff. And the reason for that is our outcomes are basically the same whether we use ECOG or not. And it saves, at least in my hands, about an hour and a half of time in the OR. I mean, this is a less than an hour surgery, right? This should not take super long to take this out. And if you're sitting around forever waiting for stuff, at least in our group, it does not make it, as you saw, our published series is 96% sort of seizure control or improvement. And if they're relatively straightforward and they localize pre-op, I just don't know that it's worth the bother and the time. I totally understand if people do it, but it's just not been the practice here for those reasons with those published data.
Do you do these in intraoperative MRI to make sure your resection's good, or no?
I do, yeah. So most of the time I'll do it. If it comes out like a chip shot and it's easy, I won't subject into the MRI. The reason I'll use the MRI is twofold. Either if I'm not sure I got it all out, it doesn't look good. And I'll tell you, we use the BK ultrasound now, which is, I think, as good or better than the MRI. The ultrasound is, the new high quality ultrasound is fantastic. But then number two, if the kid is a little kid and squirrely and they won't talk, have to get anesthesia anyway for an MRI post-op, I will just do it while they're asleep and we'll take a picture. We have a new fast sequence MRI that takes 3.5 minutes to do the scan. Now that doesn't include all the setup time and screwing around, to get the magnet out and everything, but those are the two criteria that I'll commonly use it for.
I was shocked to hear you say you don't worry about the hemosiderin. That's blasphemy. I thought that was the key to the operation.
Nope, I don't
you're
think so.
Interesting.
So just one more question, this BK ultrasound, tell us more about that, because I
have no stock in the company. It's just we had an Aloka for years and years, and that was fine. But I'll tell you what, it's like going from regular TV to high def TV, or if you've tried these little Apple goggly things, man, it's like that. It is really good. So if you can get a trial of the BK ultrasound with the cranial probe, again, I have no stock in the company, but it is super duper. It's night and day compared to the old thing we've had.
Great, thank you.
All right, Solomon, keep going, man.
All right, moving on. So this is what we did. We took the patient to the operating room, and as you can see, this is our surgical setup. Patient was positioned prone, Mayfield in an MRI or in a surgical suite with an MRI in the suite. As you can see, right side of the screen is patient slept and vice versa, and then the bottom of the screen is patient anterior. Stealth was utilized to localize the lesion, as you see by the circle, and then we drew a perimedian incision, and that's in the parietal occipital region. So we have here a surgical video. We'll try to be brief. After we made the incision, craniotomy was performed. We took it to midline, but not exposing the sinus. And after, you see the dura here, and again, we used our older ultrasound model to try to confirm that our craniotomy was adequate. And here you see this hyperechoic material that's confirming our cavernoma and the associated blood products. So again, here after the dura was open, we flapped the dura towards midline, and this is the cortical vein that we all were appreciated in the MRI. And here you see the hemosiderin blood. So working more posteriorly, we go in transcortical, and after a little bit of working along the posterior margin, again confirming with neuronavigation, and then we're slowly starting to work the margin. Here you can sort of see the fault speaking through, and again making multiple channels through the cortex just to make sure that the vein stays spayed, because as you can see, it's draining adjacent brain. And here we start appreciating the mulberry appearance, or as Ed would say, just cavernoma, not mulberry. And then now we're inspecting the deep aspect of the surgical bed and making sure we get nice hemostasis. And one more look with the ultrasound just to make sure that we don't see any residual. And as you can see here in the bottom right of your screen, we don't see anything too evident. This is the intraoperative MRI axial T2 cut after the incision has been closed. And as you can see, there's still a little bit of rim of hemosiderin stained brain, but we don't see any convincing evidence for residual cavernoma. So hospital course, the patient observed overnight in the ICU. They didn't have any new focal neurological deficits, and they were cleared by physical therapy discharge home pulse on day 2. So overall, the outcome was fairly successful. We typically here will perform surveillance MRI at 6 months just to make sure that there's no, early residual or any, concern for recurrence. And then after that, as Ed already mentioned, we'll do a serial MRI for 5 years, especially in those kids that are presented with hemorrhage, because that's when the highest risk for recurrence. And then neurology will see these patients in the outpatient setting and follow them over a course of time just to make sure that the antiepileptic medications are weaned off appropriately. And that's all I have. Thank you for your attention.
Dr. Pendrick, what do you think? Is that going to cure the seizures? You're a seizure doctor.
I would hope so. I mean, I think the approach of going for a single stage resection without using ECOG is fine. I know there's a lot of controversy about hemosiderin, but yeah, I mean, I don't know what their duration of epilepsy was prior to presentation. I may have missed that, but I think that's an important consideration as well. So I don't know if you can comment on that. What was the duration of epilepsy prior to presentation?
Solomon may not know, but it was years, so it was a little bit of a while, but
Yeah, so
it
I
went
I would
away
worry.
after.
Yeah, so I would worry a little bit about that. But if it's a, if it's a early presentation to medical care following, onset of seizures, then, I think totally reasonable single stage without any adjunctive measures. I'd still think they would probably be fine, but I do worry with the longer duration. But yeah, no, I mean, I would hope that it cures the seizures. And I was also curious, was that unblock or was that like piecemeal? I couldn't tell. I mean, like, I looking at the video, I couldn't tell if you were working the circumferential border of it and then removed it unblock, or was it kind of more piecemeal.
Uh, I don't remember exactly, but I try to do these on block.
Yeah,
I will say that sometimes they come out piecemeal if they're really big or if I'm
sure.
just having a bad day. So I would agree with you that the goal is to try to do it on block, but I have to be honest, I don't remember that particular case. And I would echo your comments that earlier surgery is better, and you'll see that in the new guidelines coming out that rather than sitting on these and treating them medically for a long time, there's going to be a real justification, I think, for early surgery with CAV-MALs that are symptomatic and mapped to the area. So hopefully more business for you.
Yeah. And additionally, I mean, one thing I was going to add when you had the question, I think Greg asked the question about having differing thresholds for patients who have cerebral cavernous malformation syndromes. I think, one thing that I think you were kind of leading to it anyway, but one thing is, intractable epilepsy related to one of the focal lesions. Certainly if repeated hemorrhage and repeated symptoms related to one of the cavernous malformations, but intractable epilepsy that can be adequately localized to one of the cavernous, like a dominant cavernous malformation, certainly would represent an indication for operative intervention.
Yeah, and I don't know what your experience has been, but Skellig's been a wizard here with these lasers. And sometimes if it's really dodgy and there's some of these CCM3 patients will have literally, dozens of them in their head and they're hard to work around. And he's done a great job sort of mapping and zapping, I think is the technical term. But, you guys are great at that. I don't do that, but that's been a wonderful addition to the tool and especially in your line of work. So I love it.
I think that's cool. We haven't done it here. Like I haven't really. I am a big proponent of minimally invasive laser ablation, but we haven't applied them to cerebral cavernous malformations. I'm not necessarily opposed to it. I know the groups have done it with good results. I'm not as thrilled about it or as enthusiastic about it, but that's something that may change. So.
Not for the CAV-MAL itself, to be clear, for
Oh, okay.
epilepsy. Yeah, no, I agree with you. I'm not a
Yeah,
fan
because
using
I know
them
there's
for
some there are
CAV-MALs.
some papers out there about it,
Yeah,
and I'm not a huge fan of that.
we're
So
on the
my
same
fault. I
page.
thought you were talking about multiple cerebral cavernous malformations. Gotcha.
No. Just
Cool.
for epilepsy control and some of these kids that are
For
tougher.
sure.
Yeah,
Yeah.
it's great.
Yeah.
All right. Well, we'll go on to the second case and then continue the discussion. Adam Kundashara is our fellow at CHOP, and we love the guy. If there's a TV version of a neurosurgeon, that's him. He did his training at Yale and then escaped and is doing his fellowship with us. In the meantime, he also did a mini fellowship with Amr Samdani at the Shrine. And he's going to tell us a little bit about an AVM case that he and Dr. Chen did about 2 months in the last 2 months. They all in the middle of the night. So he's going to tell us about one.
I'm not sure I know what that means, being a TV version of a neurosurgeon, but I think it's a compliment, so I'll take. Okay, so I've got a case for you guys. Thanks for the opportunity to present this evening. It is a case, let me see if I can get this to move forward, got it, of a 16-year-old who presents for the first time generalized tonic-clonic seizure. It was about 5 minutes. His dad witnessed him having a seizure overnight. He was brought to an outside hospital. By the time he got there, he had returned to a neural baseline. Doesn't have much of a past medical history. He does have familial adenomatous polyposis, but it's an attenuated version, so he's never had any issues with that. Sometimes he has some headaches, occasional nosebleeds, but nothing big and out of the ordinary. And when he got to that outside hospital, he got a plain CT, which I'm showing you here. You can see that superior frontal gyrus hyperdense lesion here, maybe some serpiginous structure suggesting a cortical vein. Same can be seen on the coronal. And after that head CT got transferred to CHOP for evaluation, we got a MRI, MRA, and it redemonstrates this lesion now looking more suspicious for an arteriovenous malformation. You can see that serpiginous structure is in fact a draining vein, maybe draining into the superior sagittal sinus. We'll see. I think notably, it doesn't really go too deep into the cingulate. It's definitely bound by the superior frontal sulcus, so it's a relatively confined lesion, and we are starting to be able to characterize it pretty well here. But of course, we need some dynamic imaging. I'll play here for you guys the lateral projection of an internal cerebral artery run. Play it again through. Maybe stop it there. So you can see here there's a pretty hypertrophied callosal marginal artery that's feeding the AVM. The nidus is relative, well, it's pretty compact actually, draining into the superior sagittal sinus. Oops. There we go, which we can see that here. Here's our cortical draining vein. I think notably there aren't any high-risk features. I don't see any flow-related aneurysms, no perinatal aneurysms or varices. And I think along the course of this cortical vein, you don't see any significant venous stenosis, no deep venous drainage. Just of note on this AP projection, you can see this little guy here. Can you guys see my mouse okay? You can see this little guy here, an anterior lateral, much fainter feeder, which you'll see a little foreshadowing later, actually feeds the AVM. And I think the reason why it doesn't show up very well is just a flow effect. All of the dye is going through this very hypertrophied callosal marginal, and so you're not getting a whole lot of anterior lateral feeder. So grading this thing, we talked about it a little earlier in Dr. Chen's lecture, but we've got 2 points for size. It's right on the border. It's about 3 centimeters, so I gave it a 2 for size. And then the supplemental score adds 2 more points, 1 for being less than 20 and 1 for an unruptured presentation. So what this tells us is that the perioperative morbidity is around 9%, or put another way, there's a 91 or 90% chance that if you do surgery on this lesion, the patient is either improved, really be improved. In this case, you're neurologically intact or unchanged. So maybe I'll pause there and we went through some of the management options: observation, resection, plus or minus embo or radiosurgery. And I'll kick it out to the faculty and see, this is a moderate sized lesion. Probably it's reasonable to do different types of management. How do you frame this conversation with the parents or with the patient, sort of advocate for what you think is the best option? Maybe I'll pick on Dr. Smith.
You want to pick on me?
Yeah.
I'm happy to be picked on, but if I don't want to steal the thunder of other folks.
Well, let's ask your fellow. What would you do? Would you send the kid home? Would you operate on it? Would you embolize it?
Can you go back to the you want to
Yeah,
go back to the
can you go back
MRI
to-
too?
Yeah, let me go back.
And maybe talk about some of the relevant risks given the neuroanatomic location. Like particularly, I think there's a particular neuroanatomic, there's a particular impairment that a lot of us are probably thinking in our mind, given the neuroanatomic location. You probably want to address, which would be like something in your oral boards, which would definitely come up that you want to address in discussing the risk profile for a surgical approach.
Right. So this is located in the frontal and the premotor area, the patient's left side. So what I would be worried about is temporary weakness on the patient's right side, lasting anywhere between days to weeks. But when I'm counseling the family, I would talk to them about the risk of temporary weakness. Probably at the very least 10 to 20%. But I suspect this will improve in the long term, especially considering the young age of the patient. I think overall it's fairly superficial. It's along the surface. So if you're able to do a parasagittal craniotomy, get down into hemispheric fissure and do proximal control fairly early, I suspect you should be able to go around the nidus and hug the nidus fairly well to minimize cortical transgression. So overall, I think this is a surgically accessible lesion. You can counsel them about the radiosurgery. Obviously, as we already heard about from Dr. Chen, that there is no immediate reduction in the risk of hemorrhage. But given the size, I think it would still be an adequate candidate with probably 75 to 80% obliteration, probably at 2 years. If the family elects to go that route, I think it's fine. If they want to go with the surgical route, we can talk to them about, the risks that were already addressed. But overall, I think the risk of cure of at least 90% with surgical approach. Regarding embolization, I think that's really up to the comfort level of the surgical operator. You can potentially, forego it completely and use the approach that I mentioned. You go into hemispheric, the single large feeder. You can use ICG angiography, devascularize it from the get-go and just have smooth sailing after. If you don't want to have such a big craniotomy and you don't want to put the superior side of the sinus at risk, then you can, consult with your radiology colleagues or dual trained cerebrovascular surgeons, and then they can drop a coil in there and make your life a lot.
But Solomon, I'm this patient's family, and my cousin is a neurologist, and he said there's a trial that says this is probably not going to bleed. And if it did, I want radiation. And if I do get radiation, will that decrease my seizure rate?
I don't think seizures are going to decrease or I don't think radiation is going to decrease the risk of seizures in the same degree that surgical resection probably will. That's why if the main concern here is seizures, then I would recommend doing surgical resection.
Is there data on seizures? I don't know. I'm a tethered cordologist, so I mean, we have such good data on bleed rate, but I don't know if we have data as much on seizures as we did with cavernomas, do we?
I promise I didn't share my slides with Solomon. He's just that good. And Dr. Hoyer, as always, just like foreshadowing everything here. So there is some evidence, some literature on seizures. I just kind of outlined the major points, which Solomon actually talked on almost all of them. Being able to talk to the family about observation, the quick and dirty calculation of a near 90% lifetime risk of rupture, or 2 to 3%, 2.2 annual risk of rupture. The seizure burden, 2-year seizure freedom with medical management alone. Now, the caveat is this is a pre-Aruba data. So those patients who are going for observation, maybe a slightly different cohort than post for some period. There's around 75% Engel class 1 outcomes. For resection, seizure control, also around 75% for Engel class 1 outcomes. However, some data suggests slightly higher seizure control if the nidus is less than 3 centimeters. So basically smaller the better. And if you achieve complete resection, so maybe you'd be able to quote the family something higher, like up 85% in this case. Just as a note, embolization, as it's become common practice, there's actually a relative paucity of direct supportive evidence for it. But I think, like a lot of things in our field, it's pretty self-evident. I mean, everybody knows the difference between dealing with a lesion that's like blowing up in your face, where you can't get hemostasis, and one where the flow is significantly decreased. That being said, because there's no direct supportive evidence that it decreases perioperative morbidity, I think you shouldn't take undue risk to embolize if your interventionalist thinks that maybe they can't get far enough out into the vessel to avoid having a stroke, or they think that a dissection or a rupture is likely. So there's that caveat. And then with radiosurgery, just to get back to your question, Greg, the seizure control is a little lower with reports. They vary in the literature. I got anything from 50 to 85% with Engel class 1 outcomes. And then with regard to embolization and radiosurgery, the jury really still is out regarding the positive or negative impact of embolization on obliteration rate. There are some studies showing that it improves it, some said that it's worse. However, targeted embolization can definitely be done if there are high-risk features, just to bridge, given that the effects of radiosurgery don't take.
Adam, Dr. Smith has a comment.
Oh, just to add some data to your comments, I love your comments. So there's a Lancet paper from 2014. Some jerk wrote it. I don't know who it was, but it suggests that the natural history of watching these alone from the Aruba trial, it's a sub-analysis of pediatric patients in the Aruba trial, is worse than expected, and that embolization alone actually triples the rate of hemorrhage of these. So pure embolization alone is worse than doing nothing, and embolization plus radiation might work, but is nowhere near as good as surgery. So you can cite that Lancet paper as a justification for surgery. And then for perioperative embolization of these, there's a 2015 paper from another same jerk, but it shows that the bleeding rate, I forget what the amount was, but perioperative embolization reduces blood loss by something of the order of like 15% or so, and that the overall risk of embolization intervention, with 2 papers from Darren, who is really good at this, is somewhere in the order of 1 to 2%. So what I tell families is that if you want to do surgery, surgery is better than, radiation, which is better than doing nothing in terms of cure rates, and that's the data to justify it. And then in terms of risk of embolization and benefit of embolization, it's, again, a little bit of a judgment call, but there is data to support that embolization is very safe in most cases. Obviously, you got to rely on your teammates' thoughts, and that it does reduce blood rate, and it may reduce OR time to some degree. So those are some data-driven decision points, and that's cited in the AHA guidelines as well from 2019.
I love it. Thanks, Dr. Smith. In fact, to your point, I didn't even include embolization alone as a treatment option. I was always kind of taught
And you
that,
shouldn't.
yeah, because there's no it's not like there's a fistulous point like in dural AV fistula where you can close it off. Cure with embolization alone is all it does is change the flow dynamics and take on undue risk. If you knock down the predominant venous outflow, then you're going to have basically arterial icinitis there.
I just want to make 2 comments. One is that in these lesions where you do have something to lose potentially in terms of like it's not just right frontal lobe. Adam and I were actually talking about this today because there's a kid that we're gonna do that has a very compact nidus, but right in speech. And again, it presented with seizures, otherwise unruptured. So it's a teenage boy, in his lifetime will likely bleed. So if he comes in and bleeds, he's going to be way worse, right? Like we kind of forget that part is that they're going to bleed in their lifetime. Like that's the natural history. And then 2, that radiation, although I always make them go get a radiation consult, we don't really know how they're going to react to that. Like we know if we take it out, how well we do, and that they're going to potentially take a hit, but they will recover. But with radiation, it's just who knows what they're going to swell, and what it's going to look like. And then there's really nothing we can theoretically do about it. Sometimes if we have to go in to take radiation and necrosis out, like how is that any better than just taking out the AVM? So that's like one point that I always kind of forget to, talk about is that just the unknowns of radiation, outcomes in the swelling and what that can do in that area, that location.
That's a really good point, that both of the fellows presented cases where the lesion necessarily isn't as much of a deficit as the bleed that would result from the lesions dissecting into the sensory cortex or the supplement area, or the supplementary motor moving backwards into motor area. I think that's a really great point, Dr. Chen, that sometimes deficits are worse.
And then my last point to that about the embolization only is that when I was younger, I was maybe bullied into, oh, look, we look, this got embolized and you can't see anything anymore. So I was like, okay, so I guess we'll just watch it. Never works. So if anyone on this call wants to try it, it doesn't work. So just don't go through the same mistakes. That's why we just don't do embolization only.
One comment just in terms of functional stuff. People talk about functional MRI to look at parts of the brain. You can get a fake out with the high flow of the AVM, just speaking to that with this particular case and others. We've used MEG a fair bit, not MEG from Family Guy, but, magnetic encephalography. And that tends to reduce the artifact of flow-related abnormal fMRI data. So fMRI is fine if it's, a rough call, but I would recommend MEG as another opportunity to better understand functional localization if that's relevant to the anatomy of the case.
I think one point I'd like to make here also, and we're kind of in the wild, wild west here in Florida, where we have a lot of interventionalists, a lot of physicians moving down here, and there is a lot of embolization going on, and telling our pediatric patients in these adult hospital systems that they're cured, or alternatively, we're handing the baton over to our adult colleagues and having them taking care of these patients. And I think that needs to be just really kind of, we need to take this back over from a perspective of not losing sight of taking care of the pediatric patients and taking care of their vascular malformations. As pediatric neurosurgeons, we should be able to take care of these patients and not really leave it to our adult colleagues to be taking care of them. I think that's just something I've noticed over the course of my career, is that we're losing sight of this and handing it over more and more than we should be.
All right, Adam, what'd you do?
All right, well, I mean, it wouldn't be case conference if there wasn't a case, so we made a case of it. But seriously though, going through all those points with the family, they were pretty adamant that they wanted it out. And I found that when you do lay it out, they really wanted definitive surgery. So we did try to preoperatively embolize it, and we were able to knock it down pretty well. Our interventionist could get out in that hypertrophied callosal marginal pretty well. However, some of those, let me see if I can stop it. Oh, good, that's changed. There we go. Some of the less dominant feeders then became more apparent once we knocked down the dominant feeder, just because the flow dynamics changed. So here's that anterolateral feeder, and there actually was an inferior medial kind of interhemispheric feeder as well. But it was very helpful to knock down the dominant feeder. We went intraoperatively. We just went straight for that. Solomon mentioned an early interhemispheric control, which we were able to do, take down that inferior medial feeder, and then the anterior lateral ones on the surface. To everyone's point about the location, this is the posterior border of the nidus, and I just wanted to demonstrate that we hugged it pretty tightly. As the more closer you get to the junction with motor in the SMA proper, so to speak, which some would maybe define as the first three centimeters in front of motor, the higher risk for SMA syndrome. So in the posterior margin of the AVM, we really hugged the nidus. Anteriorly, we were more liberal and left a little room of brain, so we didn't have to deal with any bleeding. And here's the intraoperative angio. There's no residual filling. There's a little bit of stasis there in that dominant feeder still. There's certainly no early draining vein. And immediately post-op, he did great. He was neuro intact. He had no SMA, fortunately. He was discharged on post-op day 2, and then I just had the pleasure of seeing him yesterday for his 1-month follow-up. So he's doing really well. He's back in school. He has no complaints, and he is still on his Keppra, although he hasn't had any seizures since surgery, and neurology is going to wean it off here in the coming weeks.
I was just curious for the crowd, is there any variability in the duration of time between embolization and operative intervention?
I mean, again, I'm not a vascular surgeon, but I know at least when I see one that's being embolized, I know that my room might be bumped, because you got to be prepared to take that kid directly to the OR as well.
Oh, for sure. Yeah, I mean, I'm assuming that the general routine practice is to go directly to surgery following embolization, but I wasn't sure if there's any variability in that.
Good question.
Members of the group.
We usually do it the next day. If it's really hairy or it's really short, we'll do it in the morning and do the case in the afternoon. But by and large, just for the sake of scheduling and ease, like today, we have an AVM we're doing tomorrow where I don't know what the hell they did down there all day, but they put some kind of crap in things. And then tomorrow, hopefully, we'll make it somewhat easier to take some stuff out. So that's our normal course of practice.
Do you have any?
I do it the next day.
Yeah, we did this case the next day as well, I think.
Do your guys embolize with onyx or particles? Or I know the onyx uses a long run, so they don't like to use it as much in kids sometimes, but sure makes for a nice case.
Now,
Yeah.
I can add it. You okay if I comment on this? Or
Yeah,
Please.
of course.
So I'm doing the endovascular fellowship as well, and typically the preference here, generally speaking, is just to knock out feeders without getting into the AVM. Because as you can imagine, if you're using liquid embolic agents like onyx or glue, and you penetrate deep into the AVM, you're really significantly changing the flow dynamics. And then you can often get some stasis or pressurization of the nidus. And I think that's why you run into hemorrhage overnight. But if you go into the distal feeders right at the junction with the nidus, you make sure that there's no adjacent parenchymal feeders, and then you block out that specific feeder, then you're decreasing the pressurization of the nidus. You're giving the brain some time to adjust before surgery and let things cool off. So that's usually our preference here. Every now and then, if there is a very simple AVM, maybe with a single feeder, and we don't see, any concern for intranidal embolization, or if there is an aneurysm in the nidus, then we'll use liquid embolic agents, but typically we'll use coils.
Actually, I want to pose a question to the group. You just use that phrase, give the brain time to adjust, because I've definitely seen in the literature this idea of stepwise change to avoid the phenomenon of AVM resection hemorrhage, which may be thought to be from, normotensive breakthrough, where you've now diverted more blood flow to what was before epidemis in normal brain. Do people feel like that's true, that when you take it down in a stepwise fashion, you see less post AVM resection hemorrhage?
I don't thankfully see a whole lot because my team is so good at making my life easy, but I would definitely say for bigger AVMs, and that's a subjective thought of what is big or what is high flow, but I am a big fan of sort of stepwise reduction of flow, even if it's just overnight. But if you think about traffic, right, it's a hell of a lot easier to reroute your traffic slowly over the evening than to just, all of a sudden drop a Jersey barrier in the middle of Route 93 or Route 95. And, I think that helps, particularly with the large AVMs and multiple feeder treatment. So I don't know what you think, in CHOP, but that's sort of been our practice.
And neither of you talked about fluorescence or any of the adjuncts other than intraoperative angiography and imaging. Bullshit or useful or?
So the fluorescence, in my mind, is only useful if you have a surface-based AVM, right? You're not going to see deep feeders that's inside the substance of the brain because it can't fluoresce through stuff. So I do think it's useful on surface-based AVMs, or if you want to see if it's shut down completely. I am in love with the ultrasound and the Doppler flow. It is just the bee's knees, better than stereotaxy. I think a Doppler, the little storm cloud AVM look on the ultrasound is super helpful. So I don't know what you folks do, but that's sort of been a big fan for me. I don't know if you have any thoughts on things, but that's what I like.
We haven't until recently trialed the ICG on our microscope, so I haven't been routinely using it. We just do intraop angio. Sorry, was that the question?
Yep.
Okay. You guys are just staring at me like I came into a totally different conversation.
Can I ask a question about, you guys have presented a lot of operative AVMs. Can you talk about future direction? Because unfortunately in Columbus, there's a lot of holohemispheric and AVMs, things that you can't necessarily operate on, that come in with seizures, that come in with ischemic events. And can the experts talk a little bit about how you're treating those and making decisions? And is there anything in the future on treating of these very troubling diseases?
I'm happy to talk if you want to talk. What would you like?
You want to go, Ed?
Sure. So, I think one of the things, Alfred C., who's one of our other faculty members, is heading a multinational study on proliferative angiopathy, these sort of big whole hemispheric AVMs that, Lejeunius first described years ago. And what we're finding is a couple of things. The group in Toronto initially did a revascularization for these. And you say, what the hell are you bringing more blood into an AVM for? But it's to help feed the steel-starved border brain that you can see with progressive atrophy and flare changes over time. And we had one of the kids we just did, Ivan, I think his name was went from not walking to walking after our revascularization. We just heard about today in clinic, maybe. So one option is revascularization, even though it seems crazy. A second is the use of a number of drug therapies, and the idea of some of these PIC inhibitors or RAS inhibitors. I think probably have a future there as well. And then lastly, sort of selective embolization of trouble spots. Alfred has one that's got a big aneurysm we were just looking at today, and the thought was maybe to embolize the aneurysm and then consider revascularization. So I think revascularization, embolization, and drug therapies are probably the big three on the future for these. But we're trying to characterize them now genetically. And if people have cases and they want to send them, we're happy to take a look at them with our registry. So that's the scoop.
Yeah, I don't have anything to add. I would say that I don't know much about the revascularization, but that's very interesting. We were just at the the International Stroke Conference, and there's a lot of research being done on drug therapies that are already like off-label use, especially in the non-CNS areas where they can kind of just use it peripherally, and then who cares that much if you lose a toe or something, that kind of stuff. So people are definitely hey, I love my toes, but
I'm lactose intolerant.
Where do you come up with these things? And so I think that just like a lot of the MEK inhibitors and tumors and stuff, like this is definitely going to be the next, monoclonal antibodies against some kind of, RAS pathway, that kind of stuff. So that's definitely in the works with a lot of basic science researchers. I would say that, we do embolize some high risk features, not routinely, but if there's definitely something that's like grown over time. But I do send a lot of them to radiation. I mean, there's certain places that will gamma knife anything. So I don't know that that's the right move, but that's certainly potentially an option for small, deep ones that are even bigger. Some institutions will do like more than whatever certain size of the gamma knife. I mean, don't know if that's the right move, but there are certain institutions that will radiate like a very, very large, not like fully holohemispheric, but like, pretty much there.
It's your last chance to ask any questions out there, future Smith-Chens.
Hi, my name is Rita. I'm from UMass. I have one question about the ultrasound again. I thought in one of your slides, Dr. Smith, there was a catheter of some sort. Do you insert the catheter into the?
Yep.
Does the catheter have a probe at the end of it, or?
Nope. So what you do is, some people do this with just stereotaxy, right? Where you pick a trajectory like you would for an EVD or something and just plunk it down along there. But what we do is you take the ultrasound, and while you're watching with the probe, you will pass the catheter in real time, and you will see the catheter. Obviously, you don't want to do this to an AVM because you hit it, red stuff comes out, you poop your pants, and then you're unhappy. But for a cav mal, a tumor, a deep-seated lesion that's hard to find, it literally takes like a minute or two. Even Solomon's been able to do it. No, that's not nice. But you can just pass the catheter down while the ultrasound shows you, and you can see yourself bumping the lesion. And then once you've done that, you just trim the top off the catheter, and then you just bring the microscope in, and you just zoop, you follow the catheter down. There's no stealth. There's no 3D heads-up display crap. There's no shift. You just follow the catheter, and where the catheter ends is where you want to be. So I love it. Mike Scott taught me that. He's the smart guy. I'm just a dummy that copied a smart guy. But, it's immensely, immensely helpful for deep-seated small lesions.
Thank you.
Dan Anderson was always big on that technique too. And I imagine he probably got it during his short time when he was up there. But anyway, he's a functional neurosurgeon. He's at Hopkins. He's awesome. But he was always big on that technique too.
Yeah. The fun on functional convergent evolution, but yeah, I think good ideas tend to rise to the surface, but it's very helpful. All right. Well, feel free to use the lactose intolerant joke. That's you know.
Well, I guess we're near the end of the time, but you brought up a good point. We're standing on the shoulders of guys like Dr. Scott, and it would be remiss not to mention him at a talk about vascular surgery. That's for sure. He certainly forgot more things than I ever knew. So
I have one question if we got one more moment. Hey, this is Neil Laxpati over at Texas Children's. A couple of you had mentioned that you weren't big fans of laser ablation for cavernous malformations. I wondered if you might expand on that a little bit, why you're not a fan.
Well, I'm the one that said it, so I don't want to speak for Dr. Chen, but I guess my thought process is most of the lesions, if you can get to them surgically, it's just such a well and time-honored way of doing things. I'm not averse to trying it if it's something like really deep-seated and hard to get to, like we had when we were thinking of lining up with a pontine cavernoma, with sort of a front all the way down the shot. But I think at least so far, I would like to see more data from the adult world to demonstrate that it has efficacy and it has long-term staying power before I say to families that this is something that's worthwhile. So I'm not averse to it for extreme cases, but since these are generally pretty straightforward, easy operations, unless they're really, really deep, I tend to think that you can get most stuff out of a little hole, whether you stick a wire in it or whether you just take it out. So it's basically because of the track record. And it's a self-fulfilling argument. I recognize my weakness in that, but that's sort of my thought process.
We've done some like enthalamus basal ganglia at the adult hospital with LIT. My husband does almost all of the laser therapies there, and so I just honestly don't like sticking like a blind probe into something that bleeds. So I'm just not like a fan of that either. We could just take it out, or I mean, especially the I think we're probably talking about the deep ones, but if we're talking about the cortical ones, like why would I stick a probe in there if I can take it out? That's how I feel about it. But I think that there are some instances where it's like a deep basal ganglia or thalamus one that you might try to do that, but I don't necessarily think they do better. I do think they swell afterwards. It's a little bit different for me just in the few cases like versus a tumor. Like I just think they swell more, maybe because it's a vascular thing, and they don't always do like amazing. It's not like as minimally invasive and as amazing as like, a really like hippocampal small tumor lesion. But again, I don't have a ton of experience. It's just like the N is like a few.
I have a question about that. Does the blood flow into the cavernoma, does that not act as a heat sink, making it harder to actually generate enough heat to ablate the tissue?
Yeah, I mean, that's one thing I was going to bring up. I mean, I agree with the comments from she, that one, when you plan these like stereotactic cases, either for ablation or stereotactic EEG, we spend a lot of time to meticulously plan trajectories that avoid vessels. So I think just from a principle perspective, I also have a problem of sticking a somewhat sharp tipped cannula into an area where there's thin walled vessels, like encouraging it to like risking it to bleed. And then, yeah, I mean, as Grandin just pointed out, yes, I mean, however slow flow it is, doesn't matter. It still does act as a heat sink. So one thing I would worry is that you have to actually increase the percentage of maximum wattage of ablation to accomplish the adequate ablation. And then I would worry about increasing edema to the surrounding tissue. So I do think it would have to, it would require a greater wattage of ablation. So that's a good point as well. So.
You're muted, Greg.
Well, if no one has any other, we're a little bit over time, but if no one has any other questions, that was really like to thank the four speakers for talking and and teaching me a lot at least. So I thought that was great. If you guys have any other questions, just forward it to one of us, and we can we know these two people, so we can send them angry emails as well, and they can get back to you.
Thanks, everyone.
Thanks,
Thanks,
everybody.
everyone. Toodaloo.
Thank you.
Thank you.